Aloha! Today we're going to talk about communication. And specifically what I want to cover is therapeutic communication between the nurse and the patient. Now, we all know that we have casual conversations with each other about the weather, about what we saw on television or the news. These are just casual social interactions. Therapeutic communication is actually a way of communicating with a patient in a therapeutic manner, okay? And there's actually a process by which we learn as nurses to do this in an appropriate way. So I think the first thing that we want to do is talk a little bit about appropriate relationships with our patients and what those expectations are. Communication itself is the exchange of information by a sender and a receiver. The message is interpreted by the receiver and returned to the sender via some form of feedback. So we can all agree on that. It's a pretty simple definition. And in terms of fostering good communication, you'll hear people in the clinical setting talk about establishing rapport with the patient. So what exactly does this mean? Establishing rapport with our patient is really getting acquainted, right? We want to show warmth as the nurse. We want to be caring. We want to be friendly. We want to have a non-judgmental attitude displayed towards the patients and the families. And then if we can do this, a sense of trust begins to develop between us and the patient. And so we really call this establishing rapport with our patient. Once they know that they're able to trust us and communicate with us in an open way, we can really provide better care. And so that's our goal. It's really essential for true client sharing to occur. Now remember, we have to have basic needs met before we can even meet other needs, right? So until the patient feels safe, until they are well fed and they have shelter, we aren't going to be able to have good communication. We also have to keep in mind that confidentiality is a major consideration. We all know that conversations between us and our patients are considered to be private, that it's important to be able to identify problems that need addressed with the client, but that they do expect that the conversations that we have will be kept confidential, meaning that I won't go home and tell my family about what I talked to my patient about, that I won't gossip about patients outside of the clinical setting or gossip about patients with my peers or other healthcare workers inside the clinical setting. So it's one thing to share information about somebody's medical health, right? Or even about their situation, right? We deal with patients that have problems with their living situation, with their family situation, and there are times when we have to discuss that with a social worker, with a physician, with another healthcare provider, and that is totally appropriate. But I think we all know the difference between doing that and gossiping about someone. Okay, and so I want you to keep that in mind when you're communicating about patients. Additional factors that kind of play into our conversations and relationships with our patients are being genuine with our patients, being open and honest, being the real you. Having some empathy for our patients. And I think it's important here to distinguish the difference between sympathy and empathy. So I want in your mind for a second for you to think about what you think the difference is between sympathy and empathy, because they're actually different. If you have sympathy for someone, you're actually feeling sorry for them or sad for them. When we know somebody who loses a loved one, we send a sympathy card because we feel sad for them, okay? Empathy is really being able to understand someone else's point of view. So being empathetic means that you're able to see the client's perspective, and you're able to even share this with others, right? So you can see it from their point of view, and you're kind of able to identify that the client is kind of feeling this way. Maybe you have felt this way at another point in your life, or maybe you haven't, but either way, you can still be empathetic in understanding what the patient is going through. The therapeutic communication is one that kind of focuses on the client's feelings, on their ideas, on their experiences and concerns in the clinical setting. It's not really a social conversation or an intimate conversation, and it really is meant to maximize the client's own strengths. Now, I want to be able to say to you here that we are not therapists, right? We're nurses. So we're not really going into a clinical setting and having a therapeutic conversation with a patient where we're trying to fix their problems. It's not what we're doing. What we're doing is providing a listening ear, and we're providing a support for them to allow them to process what's happening, allow them to maximize their own strengths, identify what their strengths and weaknesses are in any given situation. But it's really more about a patient discovering through communication, right? It's not about us trying to fix their problems. It's not about us giving them advice, okay? That is not the role of a nurse. We want to make sure that we are maintaining professional boundaries with our patients, okay? The client's needs are different than the nurse's needs. The client's role is different than the nurse's role. And there's a potential for blurring of these boundaries if the relationship moves into a social context. So what I mean by that is we don't ever give the patients our personal email addresses, our cell phone numbers. We don't encourage them to ever call us at home. These are when the roles become blurred, right? We don't engage with patient outside of the clinical setting in a social situation, okay? We don't date our patients. And so this is when the lines can become blurred, okay? We don't want to be telling the patients our problems, okay? So the patient isn't our therapist, right? And it doesn't, occasionally we will work with individuals who are very wise, right? If we're working with elderly patients, we might be working with someone who's very wise. They've lived a lot of life and they've had a lot of experiences. And we might be tempted to look up to them as a grandmother or a grandfather and confide in them and share our problems with them. This is not appropriate. This is blurring the professional boundary, okay? I am your nurse, all right? And sometimes we have to remind the patient that that is who we are. I am your nurse. My name is Mary. I am your nurse, right? Because they might start to look at us as a family member or a grandchild or a niece or a nephew. So it's really important for us to keep things in the proper perspective, okay? The nurse needs to know that if you stray away from functioning in the therapeutic environment appropriately, you can actually lose your license, okay? Here in Hawaii and in other states as well. So there's something called transference, and what this means is when there's a problem in the therapeutic relationship, when the client transfers feelings, behaviors, it's not necessarily conscious, it can be on an unconscious level, from someone in their past onto the nurse. So something about the nurse triggers a response from the patient. It could be the way you look, it could be your hair color, your mannerisms, your personality, and it could trigger anger, hostility, uncooperativeness, and resistance to therapy. On the other hand, they might identify with you in a way that you remind them of someone, and they want to have a closeness with you that probably should not take place, okay? So we need to be able to identify when this is happening. And if it is, we want to talk to our nursing instructor, or we want to talk to our nurse manager or someone else to help us sort this out. Countertransference is actually when the nurse has a behavioral or emotional response to a client. So this is actually related to unresolved feelings towards someone of significance from the nurse's past in response to the client's transference feelings. So for example, maybe the patient reminds you of your estranged father who you never had issues that were resolved with. And it can cause you to start feeling emotions when you're with the client, feelings, triggers that will happen when you're with the client. You feel angry, you feel upset, you feel depressed. You have to identify these, and again, you have to communicate with someone about this. Why is it that that particular patient really pushes a button for me? Maybe it's more than just you don't appreciate their personality. And so problems that are identified with countertransference are when we over-identify with the client. We start to develop a social or personal relationship. We start giving them advice, or we try to rescue the client. You know, we're really showing feelings of maybe disgust towards the client, or on the opposite, we have problems setting limits with the client, or we're defending the client's behavior to other team members, right? So these are all different things that can happen. And when they start to occur, you may have a coworker that says, you know, I think you're really starting to get a little too social with this client. The boundaries are being blurred. Take heed of that and do some self-reflection and ask yourself if that really is the case. You've got to seek clinical supervision or instructor for feedback if this ever happens. Okay, so let's go back into focusing on actual techniques for good communication. There are some factors that can influence our communication. Our attention, right, and our concentration. It's hard for us to be focused on a conversation when we're tired. There could be language barriers that get in the way of good communication. There can also be cultural considerations, and we'll talk about that in just a minute. There could be hearing deficits, right? Maybe our patient has a hard time communicating with us because they can't hear us. So we have to make sure that their hearing aids are properly inserted, and we also have to make sure that we are speaking loudly enough and in the ear, maybe, that they can hear better in. They may have visual deficits that can hinder communication if someone cannot see. There can be environmental factors, the time, the place, the presence of others. So for example, we wouldn't want to try to teach a patient about a new medication shortly after they just got a poor prognosis from their doctor. So the doctor comes in and says, well, I just got the results of your, a blood test. It looks like you have a rare type of blood cancer, and You're going to have to go through all these treatments and chemotherapy, and this is a very distressing time for the patient, right? They may find out that they have terminal cancer and they're going to die in 6 months. We don't want to try and go in and have a communication about teaching during this time, right? If we're going to go in and communicate, it's going to be to let them express their feelings about what's happening, okay? And they may not be ready. It's still, timing may be a problem. They may not want to talk to you right now, and that's okay. The presence of others. So for example, an adolescent, a teenager, they might not want to talk to you in front of their mom or their dad about a personal issue that they're having. Maybe they're too embarrassed to talk about birth control in front of their parent. And so make sure that you are aware that timing and presence can, impact communication. Other factors that can influence it are our perceptions. These can greatly influence our communication with another person. What do I mean by this? You walk onto the unit and you smile at your coworker that morning and say, "Hey, how you doing today?" And she snaps at you and says, "None of your business," and she walks away. Well, 9 times out of 10, we might think it's because that person is mad at us. What did I do? Did I do something to make that person angry at me? That's our perception, okay? It could be very likely that that person got in a fight with their husband before work. They came to work, you were the first person to address them at work, and you just happened to be at the wrong place at the wrong time and got snapped at. Now, I'm not excusing that nurse's behavior. It was unkind, not necessary for that person to respond to you that way. However, when we internalize it, okay, when our perception is that that person does not like me, that's going to impact your communication and relationship with that person, right? Okay, so we want to keep that in mind. So, what are the types of communication? There's verbal, and this is use of the spoken language. It can also be written communication. But words can have different meanings to different people. For example, what does a code mean? Now, in medical circles, a code means a code blue, that the patient stopped breathing and that we need the crash cart and we need the rapid response team. An 8-year-old might think that a code means a secret code that they're doing with their friends. So code can mean different things in different situations. We generally don't want to use medical jargon when we're communicating with our patients or the family. It's funny, we go to nursing school and we learn all these big words and we get really excited about being able to use these big words. But one of the true art forms in nursing is to be able to communicate kind of more complicated medical things to a patient in layman's terms, we call that. Rather than using big, lofty medical words, we want to try to communicate something in layman's terms, and that's an art form in itself, right? Being able to do that. Our pacing is important. We want to speak slowly and we want to enunciate words clearly. We don't want to mumble, especially if we're communicating with a patient or a family or a doctor. Intonation is important to consider. The tone of our voice can affect its meaning. So if I speak to you in a patronizing way, I could be offensive to you. If I talk down to you in some way, that can be patronizing and offensive. And so we know that there's also non-verbal forms of communication. Works of art can communicate a story. Music can communicate a picture in our mind. Dance, pictures, photographs, sculptures, poetry, movies, singing, these are all forms of nonverbal communication. And then we also have our 5 senses, right? And everything that does not include the spoken or written word. So examples of this are eye contact, body position, our gestures, our facial expressions, and the sounds that we even make. So for example, lack of eye contact with somebody can indicate anxiety or lack of confidence. If I won't look directly at you when I'm speaking to you, it could identify that I'm feeling defensive or I'm uncomfortable talking to you. On the other hand, and remember I said I was going to talk about cultural considerations, lack of eye contact could be cultural. Maybe it's considered threatening to have direct eye contact with somebody in certain cultures. So we need to be aware of this. So we might be interacting with a patient and they might not be making eye contact with us, and the reason may be a cultural reason, okay? And so it's important to be able to differentiate why a nonverbal type of communication is coming across to us in a certain way. It's good to be able to clarify. Working with a patient at eye level and making eye contact establishes equality in a relationship. I always make it a point when I'm having a communication to get down at the patient's level if they're laying down in the bed or they're sitting down in the wheelchair. Rather than talking down to them, I try to get down to their eye level. I do this with children as well because they feel much less threatened and they feel much more equal to you if you get down to their level. If my arms are crossed and I'm rolling my eyes while we're having a conversation, that speaks volumes. The tone of my voice, sighing, it's a nonverbal. You know, doing this, it's all nonverbal forms of communication. You're sending a message to the other person. And it may not necessarily be a positive message, okay? And so we want to be aware of how we are coming off to another person. And so sometimes it just takes times for us. People might say to you, you know, gosh, you rolled your eyes at me. Were you, intentionally doing that? Are you upset with me? And you can say, oh my gosh, I wasn't even aware I was doing that, and become more aware of your nonverbal communication. Our physical appearance says a lot about us. It's kind of what we're communicating about ourselves non-verbally. So it's important as a nurse to have a good manner of grooming and dress. We want to look professional in the clinical setting. We want to have professional behaviors in the clinical setting. Patients prefer to have a nurse with our hair tied back and short fingernails because they think it's cleaner and they feel more confident in the kind of care that you're going to give them if you look more professional. So how do we address our patients? Well, I am here to tell you that the number one way to figure that out is to ask them. Just ask them how they want to be addressed. You walk in, you introduce yourself. Hello, my name is Mary. I am a student nurse. I'm going to be taking care of you today. How do you want me to address you? Okay, and they might say, well, I want you to call me Mr. Smith. Great, you're going to call them Mr. Smith. I want you to call me Honey Boy. Well, maybe that's their nickname. It's okay to refer to them as Honey Boy if that's what all their friends call them and that's what all the other patients call them. It's what they're comfortable with. I would caution you about being careful about calling patients sweetie or honey or hun. These are kind of demeaning ways to refer to the patient. And so it's really much more dignified if you can find out how they want to be addressed and then be consistent in addressing them that way. So what is really therapeutic communication compared to other types of communication? Communicating therapeutically is a way of giving the patient permission to feel safe when communicating with the nurse. It's an avenue for the patient to express their feelings about their illness, their hospitalization, their worries, their family barriers to regaining optimal wellness, etc. Okay? So it's really an opportunity for the patient to express how they're feeling to the nurse. So it's really not a discussion about the weather. It's really not patient education, right? It's not going in and teaching them about their meds, okay? Learning that the patient hates the hospital meatloaf, well, you know, it's not really considered therapeutic communication, although maybe the hospital food is the patient's biggest problem going on. And you might sit and listen to the patient kind of complain about that. Let them kind of get that off their chest. And you can, you know, do that in a therapeutic way. And the patient will then oftentimes feel better about whatever it was that was bothering them about the food, okay? But that, therapeutic communication is usually more about how they're feeling about their diagnosis, their hospitalization, their family stressors, etc. And so what we do as nurses is we use techniques. And these are some common techniques that we use to enhance communication. And I'll give you some examples: using silence, accepting, giving recognition, offering self, and offering general leads. I'll give you a couple of examples here. One of my favorite therapeutic techniques is called reflecting. It's also called mirroring. And so an example of this would be that the patient says, "I haven't been sleeping well." And the nurse says, "So you haven't been sleeping well." It's called mirroring. When you mirror someone, you just kind of repeat back what they said to you. It's showing that you've heard what they've said and that you're giving them an opportunity to give you more information about that problem, okay? "Oh, so you haven't been sleeping well." "No, I haven't. The buzzers and beepers have been going off all night and I'm just really exhausted." Great, right? You've mirrored what they've said. They felt heard. You can also paraphrase what the patient says. So they can say, "I haven't been sleeping well," and you might say something like, "Oh, wow, so since you've been here, you haven't been sleeping well in the hospital, or was it just last night?" You can kind of paraphrase what they've said and kind of get clarification on whether it's been through the whole stay or whether it was just last night. So that's kind of an example of paraphrasing. Open-ended questions are a very good therapeutic communication technique. So here's a really good example. If I say to the patient, "Are you tired?" they can answer yes or no, okay? We don't generally want to ask yes or no questions, okay? A better way to find out about how the patient is feeling is to say, "Tell me how you are feeling." And the patient might say, "Well, I'm feeling tired because," and then they'll give you whatever their feeling is for what's going on with that. So making sure that we are able to ask open-ended questions. These will encourage the patient to elaborate on what's happening as opposed to just answering yes or no. Using silence. This is another one of my favorite techniques that students oftentimes feel very uncomfortable with, but it's a really good technique. The patient says something to you and you don't say anything. You just sit there with an attentive look on your face like you're listening. You encourage them with your eyes and your body language to go on. And there may be a few minutes or a few seconds even of uncomfortable silence. And then the patient may start talking again. It gives them an opportunity to reflect on what was just said and lets them steer the direction that they want the conversation to go in, all right? We, in our Western culture, we don't like silence. We're uncomfortable with silence. And I think as a nurse, we really want to start getting a little more comfortable with an intentional silence with our patients. Want you to know that that's okay. Gives them a chance to really think and then redirect the conversation. Something that's really not good is to agree with the patient or give approval. We try not to do that. An example of this would be, you're right that the other nurse is mean, and yes, I think you should complain to the administration. We don't really want to take that type of attitude in our communication with the patient. We don't want to agree and kind of give approval. On the other hand, rejecting is also kind of a negative way of communicating, like responding to the patient in this way. What are you talking about? That's not how it happened at all. And disagreeing with them and rejecting their feelings. Usually when somebody expresses themselves, that's a reality for them. And even if we don't see it that way from our perspective, it can be very real for the person that's expressing that feeling to you, okay? So we want to be able to respond with open-ended questions, with mirroring, with silence, with paraphrasing what the patient has already said. These are ways of encouraging good communication. False reassurance is another hindering type of communication where you say to the patient, oh, you've got nothing to worry about. Everything's going to work out fine. Well, first of all, we don't always know that, right? We don't know that everything's going to work out fine. And giving people false reassurance really kind of undermines their confidence in us, okay? Giving advice, never a good idea for a nurse. Well, if I were you, I'd try drug therapy before I would go get surgery on my neck or back or wrist or whatever. This is giving advice. We don't want to give advice, right? We are there to support our patients, and we're there to support them making their own decisions about what's best for them, okay? So in having a therapeutic communication, you can help them identify and weigh the costs and the benefits. Giving them advice about how your grandfather had that surgery, or you did this, or you did that, or this is what you think they should do, not a good idea. Giving stereotypical comments is another kind of a demeaning approach to communication. Saying something to them like, oh, keep your chin up, or things always get worse before they get better. These are stereotypical comments. We usually don't want to use these in the clinical setting. Another thing that I notice students do oftentimes when they turn in their therapeutic communication assignment is that they will change the subject, right, to a more comfortable topic. So for example, the patient says something like, I just don't have any reason to live anymore. I'm feeling so depressed and hopeless that I just don't have any reason to live. And the nurse, rather than say, well, tell me more about this feeling of hopelessness, will say something like, oh, I forgot to ask you about whether or not the doctor came in to see you the other day. You just changed the subject, okay? Because you felt uncomfortable because the patient said that they were feeling hopeless and like they had no reason to live. Yeah, that's uncomfortable, all right, for many of us. But here's the thing. Let's go back to the beginning of this talk. You don't have to fix it. You don't have to fix the problem. All you need to do is provide a listening ear and attentiveness, okay? What I mean by that is, go on, tell me more. paraphrase something that they said, showing them that you're listening. Not looking at your watch, not looking at the clock, not looking away, being there in the moment with the patient, allowing them to express themselves, coming to a close is fine, right? And then moving through the conversation. But changing the subject, making a stereotypical comment, cutting the patient off, these are all things that are going to hurt your rapport with the patient or the trust between the nurse-patient relationship, okay? Other topics or examples of poor communication techniques are defending. So for example, defending the physician if the patient is complaining about their doctor. Now you don't need to necessarily defend the physician, and you don't necessarily need to throw the physician under the bus. You can remain pretty middle of the road, all right? You don't have to take a high opinion. You don't have to take a low opinion. You don't have to have any opinion at all. You can just let the patient express themselves, mirror what the patient is saying, and encourage the patient to problem solve the issue on their own, right? Think of ways to maximize their own problem solving abilities. Probing is not always good. We don't want to appear nosy, like we're probing into the patient's business. That's inappropriate as well. And then of course, belittling or minimizing the patient's feelings. And I think we've already talked about the many ways that we can do this by making stereotypical comments, by using body language that makes it look like we are being inconvenienced by them, taking the time to share with us. I'll tell you what, learning how to have effective therapeutic communication will actually benefit you, the nurse. It will keep you from getting burnout. It will keep you from thinking you need to solve problems. It will keep you from being triangulated between the patient and the family and yourself, putting yourself in a more neutral position between the patient and the physician, the patient and the family, the patient and other staff, will really benefit you in terms of your own emotional expenditures, right? So I want you to consider these things. I want you to study more about this in your book. We're going to be talking about the therapeutic communication assignment when we meet so that you can better understand how to move forward with this. So thank you for your attention on these topics, and we will have more next time.